My name is Calvin Ludwig. I'm a second-year medical student up at Tufts in Boston, Massachusetts, where it's currently 25 degrees, so it's pretty cold. I'd really like to thank the JNIS chapter at Weill Cornell for organizing today's conference and for the privilege of speaking this morning. I'm sending my thanks also to the really distinguished panel of speakers and judges who are here with us. Today, I'm going to be talking about predicting the rupture status of intracranial or cerebral aneurysms, and specifically how we're using this new tool called radiomics to make those predictions. So an aneurysm, here's an aneurysm right here. It's an outpouching or dilatation of an artery due to the weakening of a vessel wall. So here's the parent vessel that this aneurysm is branching off of. Now, when an aneurysm ruptures, the ensuing brain bleed is called subarachnoid hemorrhage, and it is quite deadly despite advances in management, today carrying a morbidity that's reported between 10 and 20%. Now, when a patient presents with an asymptomatic, unruptured cerebral aneurysm, typically it happens incidentally when a patient's having brain imaging for a different reason. The most important thing that clinicians use to make clinical management decisions is the size of the aneurysm. And generally today, a size of 7 to 10 millimeters or greater. These larger aneurysms are suggested for surgical management. Now, radiomics. I'm going to pause just a minute for some unmuted folks. There we go. Okay. Radiomics now. Radiomics is a recently introduced automatic image processing tool for pixel by pixel, or in the case of a three-dimensional object, voxel by voxel extraction of object features. And the 4 types of features that radiomics automatically extracts are listed right here on the right. First, features based on pixel intensity histograms. Second, features based on the three-dimensional shape of the object. Then we have features based on pixel texture matrices. And then finally, some features based on wavelet transforms of the pixels. And radiomics, these features have been evaluated in really a variety of medical imaging contexts, including some that I found were differentiating between glioblastoma and anaplastic oligodendroglioma, 2 primary brain cancers, also classifying different subtypes of lung cancer based on histological specimens. And then even I found assessing the degree of liver fibrosis from elastography, which represents a non-invasive option to assess for the degree of fibrosis in folks with liver pathology. So today, my goal here was to evaluate how well these automatic radiomics features predict the rupture status of cerebral aneurysms. Can I extract some features, the radiomics features from these cerebral aneurysms, and use those to tell if that aneurysm is ruptured or not? So here's the plan. I started with 353 three-dimensional rotational angiography volumes of cerebral aneurysms. Here's a two-dimensional image of one of those angiograms from a PCOM aneurysm. Now note that 123 of them were already ruptured at the time of imaging. And these ruptured aneurysms were imaged emergently prior to vasospasm onset. And that little point there is important because vasospasm might change the shape of the aneurysm, and we wanted to study the shape before the rupture happened, and vasospasm might change the shape. Then from each of these 353 aneurysms, I extracted established features. That is, those that have been previously reported on in the literature. And then I extracted shape radiomics features from every single aneurysm. Okay, then for a univariate analysis, I performed a student's t-test, a simple student's t-test for the association between established features and rupture status and then the radiomics features and rupture status. And then for a multivariate analysis, I performed stepwise forward feature selection of established and radiomics features separately, each individually, for rupture status discrimination. So what we end up with are these, from the three-dimensional angiograms, are these volumetric representations, reconstructions of patient aneurysms. And notice that I'm chopping off the aneurysm from the parent vessel so that we can study the size, shape, and other morphological features of the aneurysm in isolation. So now I'm going to talk about some of the established and radiomics features that we extracted from every single aneurysm. Starting with those established features, those that have been reported on and published and evaluated before. Starting with the neck average. It describes how big the neck of the aneurysm is coming off of the parent vessel. Then we have the height-width ratio, which is line number 2 divided by line number 3, which gets at how long and skinny the aneurysm is. And then also the aspect ratio, line number 2 divided by line number 4. This one captures the difference between the volume of the bulk of the aneurysm, the body of the aneurysm, compared to the neck of the aneurysm through which the blood has to go through to enter the body of the aneurysm. Now let's take a look at some of those radiomics features. In particular, I want to point out elongation, which is similar to the height-width ratio in that it captures how long and skinny, like a snake, that the aneurysm is. And then also the flatness, line number 4 divided by number 2, which gets at how flat, like a disc or a pancake, that the aneurysm is. Taking a look at the univariate analysis, the student's t-test for association with rupture status. Just taking a look first at only the established features, the most important are the ones that achieved the top 2 area under the curve of the receiver operating characteristic were these 4 features right here: the aspect ratio, non-sphericity, which is how far the aneurysm deviates from a perfect sphere, height width, and then the size ratio. Now taking a look among radiomics features, the top 2 AUCs here were those 2 that I mentioned before, elongation and flatness. But now notice here, the top 2 AUCs for radiomics features, 0.71 and 0.72, are less. They're less than the AUCs for the top 2 established features. It's a similar story for the multivariate analysis, that stepwise forward feature selection that I did among established features and then among radiomics features. So the feature selection recruited these 3 variables, these 3 features among established features: height, width, size ratio, and ellipticity. That model obtained an AUC of 0.79. And then the radiomics features, among the radiomics features that I extracted, the model recruited elongation, the max 3D diameter, and the major axis length. And it obtained an AUC of only 0.75. So once again, there's an inferior performance of these radiomics features compared to those that have been previously established. That being said, a clear advantage of radiomics is its single platform use. We used 3D Slicer. It's a software that I did the entire pipeline of image processing, making those volumetric reconstructions of the aneurysms, segmenting them, and measuring the radiomics and established features all in one software. Now, in both univariate and multivariate analysis, those established features did outperform radiomics features in discriminating the rupture status of the cerebral aneurysms. Still, we believe that with some tweaking, with some adjustments, with some improvements, radiomics, those features do have the potential to become a tool of interest. Perhaps we can get them to a better predictive influence. We can improve their predictive power in deciding whether or not an aneurysm is ruptured or not. I'm part of the cerebrovascular hemodynamics lab over at the Department of Neurosurgery at Tufts Medical Center, headed up by Dr. Malek. Dr. Lauric has been extremely helpful. There's me, Calvin. And Ryan and Justin are 2 of our undergraduates in the lab who have helped us. Here are some of the references from the talk, and I'd once again, really like to thank the organizers and the faculty, speakers, and judges, and the residents who are here with us today. It's a privilege to present and be here with you all today. Thank you.
Wonderful. Great presentation, Calvin. Thank you so much.
Of course.
Any questions for Calvin?
Calvin, Dr. Puzzo, very relevant question that you're trying to answer. And is it did I get it right? Are you making an effort to document elasticity in the aneurysm wall?
The elasticity example I provided at the beginning was for liver cirrhosis from elastography. It's a special ultrasound. Yeah. So no, not here. I'm only taking a look at the shape, the three-dimensional shape of the aneurysm. We're not yet at the point where we're looking at the elastic nature of the wall of the aneurysm or the thickness of the aneurysm. These are all features that could be very relevant and how the aneurysm changes in real time. But no, for this, it was just shape.
And this is what, do you believe that this methodology can be enhanced over time to create some measure of variations in elasticity of the wall?
Absolutely. I think as imaging modalities get more and more detailed and can assess the thickness of the wall of the aneurysm, as you might know, when we inject contrast, we lose a bit of that because the contrast glows up really quite bright, and you lose a bit of the exact dynamics of the wall of the aneurysm. But the thickness or the undulation of the aneurysm could be applicable here, especially because radiomics has been applied in that realm for the liver cirrhosis patients. So definitely.
There's so much effort being made in the realm of hydrocephalus related to elasticity of the ependema and elasticity in the periventricular region, various forms of hydrocephalus and so on. And so there's a lot of research going on in that area that I think from a standpoint of imaging might be translatable here. And so I suspect that you should be treading on very fertile ground with this. So so please pursue this. This is it's very interesting. As you know, there's been a lot of work done on the area of what the anatomy, what the anatomy, what the structure is.
Absolutely.
In terms of trying to have some kind of predictive value beyond the general volume. So thank you. I enjoyed that very much.
Thank you, Dr. Puzzo. Thank you.
I just wanted to ask real quick, Calvin. That was a really good presentation. I really enjoyed walking through that, and then the images and all that. When the elasticity, just to clarify on that point, is that with voxel-based morphometry? Because you referenced VBM, and I don't know if that was what you were talking about, elasticity with voxel-based, or because you mentioned voxel-based, I wasn't sure how it related to.
Yeah, my understanding is the liver cirrhosis studies, because it was an ultrasound, which is ultimately a two-dimensional analysis, it was more along the lines of a pixel by pixel analysis there. But one thing is that the ultrasound can be a two-dimensional recording, and they can assess the change in pixel intensities, for a 5-second capture. And that gives you a really nice clue about how the elasticity is changing. So wouldn't it be nice if we could take a video of an aneurysm and then see how it's undulating and changing? That's really like next level, but maybe we'll get there.
Thanks you for clarifying. Yeah, that's great.
Wonderful. Thank you again, Calvin and Aaron, Dr. Puzzo, for your questions.
Absolutely.